Welcome to the second of 3 modules about pharmacy harm reduction practice for Arizona pharmacists and pharmacy technicians. In the first module, we discussed the meaning of harm reduction and how principles of harm reduction are and can be expressed through pharmacy practice. This module will dive deeply into why these practices are so important by focusing on the cascade of health consequences of not having access to sterile injection equipment. Blood-borne illnesses, which we abbreviate as BBIs, are an important indicator of health impact of having little to no sterile syringe access. We discussed the status of these BBIs in Arizona and reinforced the importance of Arizona pharmacies in the opioid response. For the first learning objective, participants will understand what these BBIs are, who is most affected by them, and what happens when they are untreated. This module will focus on the most common concerns, including skin and soft tissue infections, hepatitis C virus or HCV, and staph, especially methicillin-resistant strains.
Hello everyone, I'm Dr. Beth Meyerson. Let's begin this module by seeing what you already know through a series of questions. We will revisit them at the end of the training. In this section, we will discuss 2 broad types of health challenges facing people who inject drugs: blood-borne illnesses, known as BBIs, and skin and soft tissue infections, known as SSTIs for short. Take a moment to familiarize yourself with the acronyms BBIs, SSTIs, and PWID, which is people who inject drugs.
Blood-borne illnesses are diseases caused by pathogens which exist in blood or other body fluids. These pathogens can be bacterial, fungal, or viral microorganisms. According to the CDC, the most common blood-borne illnesses are HIV and the hepatitis C virus, which are pictured here. Some blood-borne illnesses live in the blood, and others cause disease when the blood is exposed to them as they enter the bloodstream. Let's first see what you know. Please pause this module and write down the ways in which blood-borne illnesses enter the bloodstream. Blood-borne illnesses can enter the bloodstream through blood or other potentially infectious material. Examples include, but are not limited to, blood, blood serum, vaginal secretions, semen, cerebrospinal fluid, pleural, peritoneal, and other joint capsules or organ fluids, and amniotic fluid.
As noted by the Centers for Disease Control and Prevention, the CDC, BBIs and SSTIs have followed the opioid epidemic. In Arizona, the situation reflects the national trend, and we struggle with huge overdose rates, as with New Mexico. Our rate, which is a number of deaths per 100,000 population, was 26.8 in 2019. It's higher now, and this meant that 1,907 people died of an overdose that year in Arizona. Here you can see the comparison between the 2013 to 2016 estimates of people living with hepatitis C in the United States and the 2020 overdose mortality rates. For this training, we'll focus on those BBIs that are common in people who inject drugs, because for this population, blood is the primary source of these infections. So this module will focus on hepatitis C, hepatitis B, and HIV comparisons using 2020 overdose mortality statistics.
Hepatitis C is a liver infection caused by the highly infectious hepatitis C virus. This is known as HCV. Hepatitis C is spread through contact with blood from an infected person. Today, most people become infected with a hepatitis C virus by sharing needles or other equipment used to prepare and inject drugs. Infection with HCV is possible through injection itself and also through dried blood remaining on the injection equipment. In fact, the CDC estimates that 8 of 10 HCV infections are caused by injecting drug use. For some people, hepatitis C is a short-term illness. But for more than 1/2 of people who become infected with the virus, it becomes a long-term chronic infection. HCV spontaneously clears in 20 to 50% of patients with acute infection within 6 months. For those who do not clear the infection, chronic hepatitis C can result in serious, even life-threatening health problems like cirrhosis and cancer of the liver. People with chronic hepatitis C often have no symptoms and don't feel sick. When symptoms appear, they often are a sign of advanced liver disease. There is no vaccine for hepatitis C. Pre-exposure prophylaxis is not recommended. The best way to prevent HCV is by avoiding behaviors that can spread the disease, especially injecting drugs, using a syringe from an infected person, or sharing injection equipment, such as syringes, cookers, and filters. These prevention solutions exist at the individual level. That is, people obtaining sterile syringes or getting treatment for opioid use disorder. They also exist at the organizational level. That is, pharmacies and other organizations dispensing sterile syringes. And they exist at the policy level. That is, state and federal laws allowing syringe sales and syringe possession without a prescription. Testing for HCV is important because treatments can cure most people in 8 to 12 weeks. HCV curative treatment has changed dramatically in recent years. Instead of injections of interferon or ribavirin without assurance of cure, treatment today involves a daily pill and cures up to 90% of those taking the treatment in 8 to 12 weeks. The downside is that treatment is expensive. The price can range from $36,000 for a 12-week regimen to $94,000 for a 12-week regimen with Harvoni. What does all this mean? It means that prevention is important and that we need to work harder relative to the prevention of hepatitis C.
A national picture is helpful, but it is also important to understand what is happening in Arizona. First of all, Arizona is among the states with higher rates of hepatitis C, HCV. We saw this map earlier as we compared HCV with overdose mortality rates nationally by state. Between 2013 to 2016, 1,210 of every 100,000 persons was infected by HCV. According to Arizona's Hepatitis C-Free Initiative, Arizona's HCV surveillance has been less than robust because A, it is likely that we are missing data from hundreds of people who test positive but do not have that test reported, and B, because testing may not be reaching the populations that need it most. Arizona is strengthening our screening in communities that need it most. A 2019 community screening study in Arizona found that screening conducted by a statewide harm reduction organization identified a higher HCV positivity rate than the state's rate because the testing was accessible by people who use drugs. The reactivity rate was more than twice the 10% rate reported by the state for community screenings in 2016. A second study, just conducted by Meyerson et al., found that Arizona methadone and buprenorphine clinics were also great opportunities to reach people who needed screening. Here, there was more than a reactivity rate, as 27.8% of the people testing with their providers in the past 2 years were diagnosed with hepatitis C. What this means is that in Arizona, we are reaching people who need access to curative treatment, even as Arizona experiences high rates of hepatitis C compared with other states. Let's pause for a moment to see what you already may know about HCV screening. Please pause, take out a piece of paper, or make a mental note with your answer to the following. Who should get tested for hepatitis C? According to the Arizona Department of Health Services and the CDC, the following people should be tested for HCV. Every adult at least once, every pregnant woman every pregnancy, and everybody with risk factors regularly. This includes everyone born between 1945 to 1965, anyone who received a blood transfusion before 1992, anyone who has been stuck with a needle or other sharp object that exposed them to infected blood, anyone who used injection drugs now or in the past, anyone who has had kidney dialysis, anyone who has HIV, anyone who was treated for a blood clotting problem before 1987, and anyone who had abnormal liver tests or has had liver disease. So if you identified any of these groups, you certainly know your stuff. Arizona Medicaid, or Access, recently established a rule that people can access curative hepatitis C treatment without being sober, that is, completely abstinent from any and all substances. This will go a long way towards eliminating hepatitis C in Arizona. Efforts like this change to Medicaid, and even our effort to increase pharmacy harm reduction practices to prevent blood-borne illnesses, has earned Arizona a national grade of B for hepatitis elimination. We are moving in the right direction. Let's pause for another moment to check in. What can Arizona pharmacies do to help eliminate HCV in our communities?
Let's switch gears now to focus on another blood-borne illness, HIV. Human immunodeficiency virus, or HIV, is a virus that attacks the body's immune system. There is currently no cure for HIV. However, it can be controlled with proper medical care. If untreated, HIV can lead to acquired immunodeficiency syndrome, or AIDS. People with AIDS have badly damaged immune systems that can lead to an increasing number of severe illnesses, which are called opportunistic infections. Without treatment, people with AIDS typically survive about 3 years. Therefore, HIV treatment to avoid progression to AIDS is crucial. Treatment can be expensive, however. The lifetime treatment cost of HIV infection is around $379,668. Early access to regular HIV testing for those at risk is important because 14% of people who have HIV don't know they have it. HIV is transmitted primarily through blood, saliva, or semen. Transmission can be prevented by a highly effective and safe treatment called PrEP, or pre-exposure prophylaxis for HIV prevention. PrEP is an antiretroviral medication used to treat HIV, but has been found to be safe for the prevention of infection and transmission as well. Arizona struggles to reduce BBIs in the population, just as other states do. But in Arizona, we also have unique issues. First, according to the CDC, Phoenix is among the top U.S. cities where people are particularly vulnerable to HIV infection. We know this because Phoenix is among cities that contribute more than 50% of new HIV cases in the U.S. annually. Second, Mojave County was identified by the CDC as being among the top 20 counties in the U.S. that were vulnerable to a hepatitis C or HIV outbreak. Third, the western states have the highest burden of HCV. 10 of 13 states have rates above the national average. Finally, until recently, it has been illegal in Arizona to possess a syringe without a prescription. The Arizona law was changed in 2021 to decriminalize syringe possession and fentanyl test strips. We will discuss that law change in the next module.
In 2019, 18,468 people in Arizona were living with HIV, which means that 779 people out of every 100,000 had HIV disease. Now that number is conservative because 21.2% of Arizonans are at risk for HIV, but aren't getting the message about PrEP or access to PrEP. An Arizona study by Carter et al. Found that among people who inject drugs, 63% were unaware of PrEP. And if they did know about it, they didn't think that the treatment was meant for them. This was because they felt that HIV was only a sexual risk and not an injection drug use risk. About 12% of those who test positive for HIV or tested positive in 2019 reported injection drug use risk. This is in Arizona. Among Arizonans who are HIV positive, 7% of those who are men also reported injection drug use, while 24% of the women who are HIV positive had a history of injection drug use. This slide is a depiction of what we call the HIV cascade, a tool used by public health to understand the effectiveness of HIV prevention and treatment access. It helps us understand who is at risk and who then has access and how we need to prioritize our resources.
In this segment, we will focus on the skin and soft tissue infections, known as SSTIs, and their sequelae that are most common among the people who inject drugs. SSTIs are the most common reasons people who inject drugs seek medical care. They're the most common acute infectious complication of injecting drugs and are reported by 64% of people who inject over 1 year. Cellulitis and abscesses account for more than 50% of these SSTIs. Treating these infections is critical because they can cause even more serious health issues, such as bacteremia and subacute endocarditis. The SSTIs in focus for this module include cellulitis and cutaneous abscesses. The most common SSTI in people who inject drugs are most often seen at the sites of injection. The arms, the legs, and the buttocks being the most common of these injection sites, followed by, less common, the neck, the groin, and the torso. Cellulitis develops as a result of bacterial entry through skin breaches and manifests as skin erythemas, edemas, and warmth. Skin abscesses are collections of pus within the skin or underneath it. Abscesses can, of course, be very painful. Methicillin-resistant Staph aureus, MRSA, is about 16 times more common in people who inject drugs compared to people who do not. Invasive methicillin-resistant Staph aureus, again, MRSA, has dramatically increased, as you can see in this slide, from 4.1 to 9.2%. It's the leading cause of endocarditis in people who inject drugs. It's also strongly associated with HCV as well as hepatitis B virus. So methamphetamine, which impairs wound healing and depresses immune function, creates added risk for people who inject drugs to develop MRSA. Also, black tar heroin, implicated as an agent in soft skin and tissue infections because of its bacterial contamination, is an important issue. 1 point relative to black tar heroin, however, is that it's slowly being replaced with what may be even more dangerous, and that is fentanyl. So also called blues or M30s. Fentanyl is, again, something that is in Arizona in the form of these pills that you see in the slide and creating issues that may somewhat replace the issue of the black tar heroin, but then cause other problems. So let's see what you know at this stage about the SSTIs, including MRSA.
Behavioral practices which contribute to SSTIs include needle licking before injection, the use of another person's injection equipment, the use of a non-powdered drug, such as black tar heroin versus, say, white powder heroin, frequent injection, what's called skin popping or subcutaneous or intradermal injection, an intramuscular injection or muscling, or all the above. In this section, we will discuss the importance of early identification of blood-borne infections and skin and soft tissue infections, and what pharmacy practitioners can do to assist this public health effort to reduce them or eliminate them completely. As with all communicable health conditions, early identification stops the spread of infection to others. It also allows for treatment to reduce HIV or even cure conditions such as hepatitis C. This is easier said than done, of course, in populations that don't feel they are at risk for blood-borne infections or skin and soft tissue infections. So let me ask you, what can pharmacy staff do to help their customers who inject drugs? How do we help them identify SSTIs and BBIs early on? Let's first pause for a moment before we answer that. We'll return to it. So let's take a minute to reflect on an important question, because this emerges every time we work with pharmacy staff to try to understand their public health roles in the opioid, HIV, or hepatitis epidemics. When you think about your pharmacy, who are your customers or patients? How do we decide who our customers are? Must they be people who we have served before, so no new customers? Are they people who want to purchase services or products that we personally or from a pharmacy policy perspective deem appropriate, so those who do not fit in that category are suddenly not our patients? Can a person be in both categories? I'm a customer at Fry's, for example. I pick up my medications monthly. That, by definition, would make me a pharmacy customer. But do I stop being a pharmacy customer if I also ask to purchase a bag of 10 syringes to protect myself from HIV or hepatitis C? Must I also appear a certain way? It's important for all of us to interrogate our understanding or mental models of who a patient might be in our pharmacies. We all construct ideas or conceptions of who a customer or patient might be. We also construct models of who a person who uses drugs might be, or a person who has HIV might be, or a person with endocarditis, etc. There are many ways that pharmacy staff can serve their clients within the scope of pharmacy practice while helping them prevent blood-borne illnesses and skin and soft tissue infections. Here are just a few. Can you think of others?
Given that injection drug use is associated with infective endocarditis, it is important to identify health risks early and before they become difficult to manage. As Keishan and colleagues found in one academic hospital in Ohio, HCV and HIV screening occur at higher levels when patients disclose a history of injection drug use, but not when they present with infectious endocarditis. Identifying skin and soft tissue infections early is important because the cost of treating one person admitted to the hospital for infectious endocarditis was greater than the initial budget of the local syringe exchange program. Referring pharmacy patients to healthcare for evaluation of skin and soft tissue infections will reduce health issues that follow untreated skin and soft tissue infections. A national study of inpatient hospitalizations from 2002 to 2012 found that hospitalizations associated with opioid use dependence and serious infection increased almost twofold, quadrupling the costs of caring for these patients. This is why we say that harm reduction services in pharmacies can save lives. We do this through our care of patients and their needs within the scope of pharmacy practice. There are many things that pharmacists and pharmacy technicians can do as they serve pharmacy patients who inject drugs. These activities require very little time by pharmacy staff if resources and information are available. For example, pharmacies can sell syringes without a prescription to patients requesting this. The moment of sale is also an opportunity to ask patients about their health and educate about skin and soft tissue infections and blood-borne illnesses. When health conditions are observable, use the opportunity to speak with the patient about the importance of healthcare and recommend safer injection behaviors. Recommend over-the-counter treatments that can help reduce further infection and protect the wound, such as sterile water, alcohol wipes, and bandages. Refer patients to local services for HCV and HIV screening, healthcare to assess skin and soft tissue infections and address them, or local syringe service programs for ongoing access to syringes and proper disposal when the pharmacy is not open. Referral to healthcare might be appreciated if the patient has not had negative experiences with healthcare providers. If they have, as we have found in Arizona due to healthcare provider stigma, pharmacy staff understanding and offer of the referral information for use when the patient is comfortable would likely be appreciated. Stock and dispense naloxone. Many pharmacies participate in the subsidized naloxone availability program sponsored by their state health departments. In Arizona, pharmacies can become distributors of free naloxone, which can be important if patients do not have health insurance or economic resources to pay for it. Naloxone is increasingly important due to the increased availability of fentanyl, which is over 100 times more powerful than heroin. While many pharmacists have become aware of blood-borne illnesses and skin and soft tissue infections, Arizona pharmacists should also recognize the importance of their role in blood-borne illness and skin and soft tissue infection prevention and treatment. Pharmacies are trusted healthcare partners.